Sir, I thank Kalpana for allowing us to share our experiences. I'll be presenting two cases, two interesting and a very challenging cases in uveitis. I have no financial disclosures. Our first case is a 60-year-old male who had a history of cataract surgery in both eyes 2 years ago. And I would like you all to pay very careful attention to the history. He had on and off occurrence of redness in the left eye, and this has been going on for the last 8 months. He has a transient drop in vision every time, and then this was preceded by a sudden shower of floaters in the left eye. He was also a hypertensive on ecosprin, and he was diagnosed elsewhere with transient ischemic attack, and they were suspecting probable low-grade endophthalmitis, and he had a secondary glaucoma, and he was advised vitrectomy. So he had come to us for a second opinion. At that time, his vision is 6/6. His right eye was pseudophakic, IOL nicely placed in the bag. Left eye undilated, everything looked okay, but when we dilated the eye, he had an IOL in the sulcus. It was slightly decentered temporally, and he had the capsular staining inferiorly. I'll show you the photograph. And his anterior segment just showed pigments and a chronic flare. His intraocular pressures were normal in the right eye. Left eye, with maximum anti-glaucoma medications, his pressures were 26, and he was on topical steroids with maximum anti-glaucoma medications. So if you see the pictures, the bottom area, in this, the dilated, he had these capsular staining. Just inferiorly, and the dilated, he had a pigmentation on the capsule. And this is very important. We did a gonioscopy, and he had microhyphemas in the angle, along with some amount of peripheral anterior synechiae. So this was a diagnosis of uveitis glaucoma hyphema syndrome, which was misinterpreted as probably a low-grade endophthalmitis. And we did a UBM for confirmation, and we found that the haptic was actually eroding the iris root. And he was having transient hyphemas each time there was a rub. And these transient hyphemas was actually, by history, he interpreted it as a sudden shower of floaters, and this was followed by a glaucoma or a spurt in intraocular pressure, and that's how he had a transient drop in vision. So this patient, we took him up and removed this IOL and placed a 3-piece IOL, a different IOL in the sulcus. And he has never had any recurrences. It's been 2 years now, and his intraocular pressures are 16 in that eye without any medications. So it's very important to pick up subtle signs in the history as well as a capsular pigment which we were seeing on dilatation. The second case is a 40-year-old immunocompetent lady. Again, she has a history of primary open-angle glaucoma. She had the characteristic Fuchs heterochromic iridocyclitis with glaucoma in 2005, and that time the IOP maximum recorded was 28. And the ophthalmologist, we had started her on fluoromethylone eye drops along with butoxil for control of the inflammation and the pressures. In 2009, she came to us with a very high IOP of 42 with reactivation of anterior uveitis. And she was recently started on fluoromethylone since 4 days, and the IOP was not coming down. At that time, we did an AC tab, and the AC tab was positive for cytomegalovirus. And this was negative for all other viruses. And the serology, although we do not attach much importance to that, but at that point of time, we were keen on looking at that as well, and that was also positive. And this is the picture. This is the eye, which showed the characteristic moth-eaten iris pattern. There was a central KP, which is very unusual looking. And if you see that central KP, again, I'm not sure how do I do the pointer. Okay. This is a central KP, and if you see very carefully, there's a kind of halo around that KP. And this is very interesting, and all her investigations were negative. At that point of time, we decided to give her a course of ganciclovir, and we started her on ganciclovir, both oral and the gel, and she was also on anti-glaucoma medications. She did very well, her pressures were under control, and this was a patient with CMV anterior uveitis. Now, CMV anterior uveitis presents characteristically with this kind of owl-like pattern around the keratic presbytery. Actually, that's the diseased endothelial cell, and with pressures which are very alarming, with around 40, 50. She was doing very well, and in Bangalore the distances are so large, so she stopped following up with us and she was following up with her local ophthalmologist. One period of time she developed a skin allergy to the Conbidian medications, and unfortunately the ophthalmologist started her on prostaglandins after that. So this is what happened. Within 4 days she comes with blurring in vision. Her vision is still 6 parts and her IOP shoots up to 50. And again, if you see that characteristic thing, you have this halo-like appearance with active lesion. And these are the other pictures. And the whole endothelium was studded with these kind of lesions. So we repeated the TAP, and the TAP was positive for CMV. Her inflammation and IOP did stabilize with the discontinuation of the prostaglandin, and we had to add the steroid. However, in due course, she underwent a filtering surgery in 2011, where we repeated, and the aqueous was again sent for examination, and this came out as positive for CMV. And after that, we've had only one episode of reactivation in 2012, for which she was treated with dexamethasone drops, and since then her pressures are stable. So this is her eye, different stages, and this is the episode with the reactivation. So what is interesting is CMV anterior uveitis is relatively new, which we do see in our patient population as well. And these are very common and usually seen in patients with diffuse heterochromic iridocyclitis-like pattern, although we can see it in patients without these iris atrophic changes. But what is important is a characteristic lesion with a halo, which usually accompanies most of these patients with CMV anterior uveitis. And it is worth doing a TAP in these patients because some patients are unnecessarily put on immunosuppression for this. So this case highlights the new etiology, the CMV in immunocompetent patients. Thank you so much.
Thank you, Dr. Kalpana.